Hi everybody, welcome to our module on esophageal disorders. We'll start by talking about one of the most common esophageal diseases and one that you are very likely to encounter in your clinical rotations, and that is GERD, which stands for gastroesophageal reflux disease. And GERD happens when gastric juice from the stomach refluxes back into the esophagus, and as you know, gastric juice contains acid, and that acid can be damaging to the lining of the esophagus. And this disorder occurs because of a failure of the lower esophageal sphincter to maintain its closed status and prevent the backflow of acid into the esophagus. There's a decrease in lower esophageal sphincter tone in GERD. The precise mechanism is not well established, and I've bolded the words lower esophageal sphincter because this is very high yield for you to know for your exams. When gastric acid refluxes into the esophagus, it can cause reflux esophagitis, which is inflammation of the epithelial layer of the esophagus. Recall that the esophagus has an epithelial layer made up of stratified squamous epithelial cells as shown in this picture on the slide here. This layer can become inflamed. It can develop erythema, which is redness from increased blood flow, and edema from the inflammation. In addition, erosions of this layer can occur where there's loss of the epithelial layer from the gastric acid. When you perform biopsies in patients with reflux esophagitis, there are some classic histology findings that you should know, especially because these are buzzwords for your exams. So the first thing you should be aware of is that the basal zone of the epithelium can develop hyperplasia. This is the basal zone of the epithelial down here, and it can start to multiply and develop hyperplasia in the setting of exposure to stomach acid. In addition, the lamina propria layer of the esophagus has papilla, not shown on this slide here, which can elongate and begin to extend outward. And then finally, you can see the presence of eosinophils and neutrophils in reflux esophagitis. Now, neutrophils may seem obvious because there's inflammation going on, but eosinophils are somewhat surprising, and they are a characteristic cell that is seen in reflux esophagitis. Normally there are no eosinophils in the mucosal layer of the esophagus, but they can develop in reaction to reflux esophagitis. This will often confuse students because they will think the presence of eosinophils indicates an allergic disorder. There is a rare disorder called eosinophilic esophagitis, which we'll talk about later, but you should know that eosinophils may also occur in the esophagus in response to esophagitis from reflux. Many of the risk factors for GERD are called lifestyle risk factors. Patients who choose to drink too much alcohol or smoke are at increased risk for GERD. Patients who consume lots of caffeine or fatty foods or who are obese are at increased risk for GERD. And then finally, if you have a hiatal hernia of the stomach and the esophagus, which I talk about in the hernia modules, you are at increased risk for GERD. Many of you likely know that the symptoms of GERD are called heartburn. Heartburn is a retrosternal burning sensation in the chest. It classically occurs after meals. It's worse when lying flat, and it can sometimes be worse at night when patients lie down in bed after a big dinner. What many people do not know is that GERD often causes symptoms other than heartburn. It can cause dysphagia. This is from painful esophagitis. It can hurt to swallow. The reflux into the esophagus can also reach the lungs and cause respiratory symptoms. Reflux can enter the respiratory tract. This can cause asthma. Classically, this presents as adult onset asthma. Most patients with asthma have symptoms that begin in childhood. If a patient presents with new asthma in adulthood, one of the things you should think of is that they may have GERD. Patients can also develop a cough and dyspnea related to GERD. And then finally, all that reflux of stomach contents can lead to damage to the enamel of the teeth. Babies can develop reflux because they have an immature lower esophageal sphincter, and babies can't complain of heartburn symptoms like burning in the chest, so instead they will develop vomiting and frequent crying. And many babies have problems where they spit up food and they cry a lot, so often empiric therapy for GERD is attempted to see if it improves the baby's symptoms. We'll talk about medical therapy for GERD in a minute, but first you should know that weight loss is an excellent therapy for GERD. I have had patients who have lost 10 pounds of weight and found their heartburn gets much better. In addition, when you diagnose someone with GERD, you need to have a discussion with them about the common triggers of heartburn. Avoidance of fatty foods and caffeine can help to limit GERD symptoms. So can avoidance of chocolate, spicy foods, carbonated beverages, and finally peppermint is a classic trigger for GERD. Patients who have severe symptoms can be offered a surgery. It's called a Nissen fundoplication. This is a picture of it shown on the screen here. In this operation, a portion of the stomach is wrapped around the lower esophagus in order to improve the tone of the lower esophageal sphincter. This is reserved for patients who fail medical therapy. The medical therapy I talk about in the module on GI pharmacology, but I'll just briefly review here the two classes of drugs that are commonly used. The first group are the histamine H2 blockers. These are drugs like famotidine and ranitidine and nizanidine and cimetidine. These all block histamine receptors in parietal cells, which decreases the acid content of the stomach, and that can improve GERD symptoms. What's more commonly used in the modern era are the more powerful proton pump inhibitor drugs. These are drugs like omeprazole and pantoprazole and lansoprazole and esomeprazole. These inhibit the potassium-hydrogen pump in the parietal cells, and they reduce the acid content in the stomach as well. In addition to heartburn and other GERD symptoms, there are some structural problems that can develop in the esophagus as a result of GERD. These include ulcers in the esophagus, fibrosis, and strictures. They're all potential consequences of GERD. The acid destroys the mucosa, and when this happens, you can develop an ulcer. Eventually, that ulcer can heal and be replaced by fibrous tissue, and the fibrous tissue can obstruct the lumen of the esophagus. That's called a stricture in the esophagus, and that can lead to problems swallowing, which is dysphagia. There's another way the mucosa of the esophagus can get damaged and develop strictures in addition to GERD, and that's from ingestion of lye. And they like to ask you about this on step 1. So let me review this now. Lye are substances that are alkali. They are basic, very different from the acid in the stomach. They usually contain either sodium or potassium hydroxide, both of which are bases. And you can find these in household cleaners and drain openers and many household cleaning products. And they are sometimes ingested accidentally by children. This causes liquefactive necrosis of the esophageal mucosa. There's rapid injury through the mucosa into the wall of the esophagus. Eventually, the lye reaches the stomach, where it's neutralized by the stomach acid, and the child usually recovers. However, later in life, as a result of ingestion of lye, these children can develop strictures in the esophagus, and it's important you know about this, especially for step 1. Back to our discussion of GERD, let's talk about Barrett's esophagus. This is a feared complication of long-standing untreated heartburn because it's a precursor for esophageal cancer. Barrett's esophagus is metaplasia of the esophageal lining. The normally squamous epithelium is converted into intestinal epithelium from long-standing exposure to stomach acid. If we look at this picture on the screen here, there is a point where the esophagus meets the stomach, and that is called the squamocolumnar junction. That's where the squamous epithelium of the esophagus converts to the columnar epithelium seen in the stomach, and that point will begin to move upward in Barrett's esophagus as the mucosa down at the bottom of the esophagus converts to intestinal-type mucosa from exposure to acid. On the left side of the screen is a normal esophageal mucosa. It's composed of non-keratinized squamous epithelium. With exposure to stomach acid, it begins to look like this picture on the right, which is a picture of Barrett's esophagus. You can see that there are now crypts present. There are also many goblet cells present. It's described as intestinal mucosa, which is non-ciliated columnar epithelium with the presence of goblet cells. The way Barrett's esophagus is diagnosed is via endoscopy. This involves putting a camera into the esophagus, and what you will see is something like this picture on the screen here. The white mucosa is normal squamous cell epithelium of the esophagus. The red mucosa here is Barrett's esophagus. That is esophageal mucosa that has undergone metaplasia, and if Barrett's is seen, usually regular surveillance endoscopy is done with biopsies to look for carcinoma and try to diagnose and treat esophageal cancer in its earliest stages. The reason the development of Barrett's esophagus is such a concerning finding in patients with GERD is because Barrett's esophagus is a precursor for certain types of esophageal cancer. So let's talk about esophageal cancer now. There are two types, squamous cell and adenocarcinoma, and the risk of both types is increased among smokers. It's a very important risk factor for esophageal cancer. Both types tend to present late with advanced disease and METs, and the classic presentation is progressive dysphagia. Progressive means that the dysphagia starts with solids and progresses to involve liquids as well as the tumor grows. When the tumor is small, there will be dysphagia or difficulty swallowing solids, but liquids can easily get past. As the tumor gets bigger, it begins to obstruct the movement of both solids and liquids. Other symptoms may also occur. Weight loss is a classic symptom, so is hematemesis. Adenocarcinoma is the most common form of esophageal cancer in the United States. And in order to understand how adenocarcinoma develops, you need to appreciate that normally we don't have glandular tissue lining the lumen of our esophagus. Normally we have a squamous epithelium. So in order for adenocarcinoma to occur, a patient needs to have GERD that leads to Barrett's esophagus, and then as we've just discussed, as a component of Barrett's esophagus, glandular epithelium develops lining the esophageal lumen. And so once you have that glandular epithelium, the patient can then go on to develop adenocarcinoma.
So if you understand this, it's easy to remember that adenocarcinoma usually occurs in the distal third of the esophagus. That's the portion near the stomach where stomach acid from GERD can change the lining of the esophagus. You should also know that obesity is a risk factor for esophageal cancer, and you can just think of a patient with large amounts of adipose tissue pushing on their stomach and shoving all that acid up into the esophagus. That's the way I've always remembered that obesity and any cause of GERD is a risk factor for getting acid into the lower esophagus, leading to Barrett's esophagus and adenocarcinoma.
Worldwide, the most common form of esophageal cancer is squamous cell carcinoma, and in contrast to adenocarcinoma, this occurs in the middle or upper esophagus. And things that are risk factors for this type of cancer are things that can damage the upper esophagus. So consuming certain types of food like alcohol or lots of consumption of hot tea, these can damage the mucosa in the upper esophagus, and that can lead to squamous cell carcinoma. Anything that obstructs the passage of food and liquid through the esophagus can lead to damage at the upper esophagus from backup of food. So achalasia, which we'll talk about later, is a risk factor for squamous cell carcinoma. So is the presence of esophageal webs, which can lead to a backup of food. We'll talk later about a Zenker's diverticulum, which can obstruct the movement of food. This can lead to squamous cell carcinoma. And finally, we mentioned lye ingestion before, and that's a risk factor for esophageal cancer. There are certain symptoms that are unique to this type of cancer that are due to its upper location in the esophagus. So patients with this type of esophageal cancer tend to develop a hoarse voice, and that's because the recurrent laryngeal nerve can be involved in the upper esophagus. These patients also tend to develop a cough, and that's because of tracheal involvement near the upper esophagus. The lymph nodes where these cancers drain to are going to be different because the lymph nodes for the upper and middle esophagus are different than those that drain the lower esophagus. The upper esophagus is drained to lymph nodes in the neck, like the cervical nodes. If you look at this picture over here, these are the cervical nodes in the neck, and it should make sense to you that the upper esophagus, which is not far away, drains to those lymph nodes. The middle esophagus drains to the chest. It drains to the mediastinal nodes and the tracheobronchial nodes. These are the mediastinal nodes shown here. The tracheobronchial nodes are not shown in this picture. The lower esophagus drains towards the abdomen. That's easy to remember because it's close to the abdomen. So it drains to the celiac nodes near the stomach and the gastric nodes also near the stomach. Earlier, I talked about reflux esophagitis, and reflux is certainly the most common cause of inflammation of the esophagus, but there are other causes, and let's talk about those now. So first of all, certain infectious agents can cause inflammation of the esophagus. Candida can infect the esophagus, especially in patients who are immunocompromised. It causes white membranes to form in the esophagus. This is a picture of a patient with candidiasis in the esophagus. On biopsy, you will see pseudohyphae, which are characteristic of Candida. I talk more about pseudohyphae in the infectious disease modules. HSV1 can infect the esophagus. Usually this virus causes oral herpes, but it can involve the esophagus, and it will lead to punched out ulcers that you can see on endoscopy. And then finally, if you are very immunocompromised, such as aged patients with a CD4 count under 50, you can get esophagitis from cytomegalovirus. Cytomegalovirus characteristically causes linear ulcers in the esophagus on endoscopy. A rare cause of esophagitis is called eosinophilic esophagitis. This is an allergic reaction to an unknown antigen. It's an immune-mediated process, and patients with eosinophilic esophagitis present with dysphagia. They will complain of difficulty swallowing due to esophageal dysfunction. On a biopsy, you will see an eosinophil predominant inflammation, which should make sense to you given the name eosinophilic esophagitis. It's very important to make a diagnosis of eosinophilic esophagitis to exclude other causes, especially GERD. Remember what I told you before, GERD can lead to eosinophils in the esophagus, so you need to exclude GERD before you can make this diagnosis. The classic scenario for a patient with eosinophilic esophagitis is someone who has dysphagia and a poor response to GERD treatment and eosinophils seen on biopsy. That is a patient who may have eosinophilic esophagitis. Moving on to other esophageal disorders, let's talk about achalasia. Achalasia is an inability to relax the lower esophageal sphincter, and if you cannot relax the sphincter, you will not be able to pass food from the esophagus into the stomach. It occurs due to loss of ganglion cells in Auerbach's plexus. It's very high yield to remember this fact for step 1. This plexus, recall, is found in the muscular layer below the submucosa. Often achalasia is an idiopathic disorder. However, you should know that it is associated with chronic Chagas disease. Chagas disease is common in South America. You get infected with Trypanosoma cruzi through the bite of the reduvid bug. I've shown you a picture of reduvid bugs on the screen here to remind you of this. There is an acute Chagas disease, which is a febrile illness, but if you are chronically infected, one of the consequences of that chronic infection can be achalasia and dilatation of the esophagus. The symptoms of achalasia are dysphagia to both solids and liquids. These patients have a closed lower esophageal sphincter, so solids and liquids are unable to pass from the esophagus to the stomach. And contrast this with a partial obstruction due to a tumor. In that situation, solids may get stuck in the esophagus, but liquids will pass normally. That's not the case in achalasia, where you have dysphagia to both solids and liquids. These patients also suffer from bad breath. That's because of accumulation of food in the esophagus. And as I told you before, this chronic accumulation of food can lead to inflammation, and that makes this a risk factor for squamous cell carcinoma of the esophagus. There are a couple of ways to make the diagnosis of achalasia. The first way is to do a barium swallow. If you ask the patient to swallow barium and then you take an X-ray image of their esophagus, the classic finding is called a bird's beak. It's shown in this picture on the right side of the screen here. The esophagus is dilated from the backup of food over time, but the lower esophagus is narrowed down to a point. That's called a bird's beak, and the reason it's narrowed is because that lower esophageal sphincter is tight and closed. Another way to make the diagnosis is by esophageal manometry. This involves using a device that can measure the pressure or tone in the lower esophageal sphincter. This test will show a high lower esophageal sphincter tone in achalasia, and it's important that you understand that this is different from what you see in scleroderma. I talk about scleroderma in the immunology modules. However, scleroderma can involve the esophagus, and in contrast to achalasia, patients with scleroderma have dysphagia with low lower esophageal sphincter tone. That makes it different from achalasia. Esophageal varices are dilated submucosal veins. A varix is a tortuous dilated blood vessel. Varices are multiple tortuous dilated blood vessels, and that can occur in the lower third of the esophagus in patients who have portal hypertension from cirrhosis. I talk about the mechanism of these varices in more detail in the module on cirrhosis, but the important point here is that this can lead to upper GI bleeding. This is called a variceal rupture. It's painless bleeding from the esophagus. It results in vomiting of blood. This is a common cause of death in patients with end-stage liver disease, and because of the danger of these varices, cirrhotic patients are often screened with endoscopy, and if they develop a varix, it can be treated endoscopically. The treatment for variceal bleed is to perform an emergent endoscopy and use a technique called banding or ligation, where you try to eliminate the varix so that it will no longer bleed. The Mallory-Weiss syndrome is damage to the esophageal mucosa at the gastroesophageal junction, and I've bolded the word mucosa because they like you to know which layer of the esophagus is involved in this syndrome. It causes painful hematemesis, so there are many things that will cause people to vomit blood, but if they vomit blood with epigastric pain or pain in the back, you should think about the Mallory-Weiss syndrome. It's caused by severe chronic vomiting, which results in damage to this portion of the mucosa, so this can be seen in alcoholism. It can also be seen in bulimia. A more serious condition is called the Boerhaave syndrome. This also results from severe chronic vomiting or retching, but unlike the Mallory-Weiss syndrome, which only causes damage to the mucosa, in this case, patients develop transmural rupture of the esophagus. This will result in pain, and you can also find evidence that air has exited the esophagus. A classic finding is air in the mediastinum. On chest x-ray or CAT scan, this is called pneumomediastinum. You can also sometimes see air under the skin of the neck. This is called subcutaneous emphysema. Sub-Q emphysema is a physical exam finding. When you press on the skin of the neck, you can feel bubbling and crackling from the air bubbles underneath the skin. If you look at the chest x-ray on the left side of the screen, there's a subtle finding, but there's a black space next to the aorta. That represents air in the mediastinum. You can also see air tracking along the aorta in this CAT scan over on the right side of the screen. Both of these images have evidence of pneumomediastinum, which can result from Boerhaave syndrome. Esophageal webs and rings are extensions or protrusions of the esophageal mucosa into the lumen of the esophagus, and these can obstruct the movement of food and lead to dysphagia. The bottom right side of the screen is a picture of the normal stratified squamous epithelium of the esophagus, and you can imagine that if it extends into the lumen of the esophagus, it could obstruct the movement of food. If we look at a cross-section of the esophagus, a ring is a circumferential extension of that mucosa. A web is some other growth of that mucosa that is not circumferential. Webs are more common in the upper esophagus, rings are more common in the lower esophagus, and both webs and rings carry an increased risk of squamous cell carcinoma, and that's easy to remember if you appreciate
indicate that it is the squamous epithelium that is extending into the GI lumen. A Schottky ring is a special type of esophageal ring that occurs at the squamo-columnar junction at the junction with the stomach. It's a common cause of dysphagia to solids. This is a picture of one seen by endoscopy. You can see this ring of mucosa that is extending into the lumen of the esophagus. Because of its location at the junction of the stomach, there's squamous mucosa proximally in these rings and columnar mucosa distally. The Plummer-Vinson syndrome is a rare condition with a poorly understood cause. It presents as a classic triad of iron deficiency anemia, a beefy red tongue, and a presence of an esophageal web. The beefy red tongue is from damage to the mucosa of the tongue and exposure of blood vessels. This is common in middle-aged white women. The last topic I'll discuss in this module is a Zenker's diverticulum. This is a special type of diverticulum that occurs at the junction of the esophagus and the pharynx. It results from protrusion of the mucosa and submucosa layers through the muscular wall of the GI tract. Recall that there are three upper layers to the GI tract. The top one is the mucosa, followed by the submucosa, followed by the muscular layer. A true diverticulum is an outpouching that involves all three layers, and true diverticulum are relatively uncommon. The most important one for you to know is a Meckel's diverticulum, which is a congenital anomaly of the intestines. A Zenker's diverticulum is called a false diverticulum, and this occurs because there's a breakdown in that muscular layer that allows the mucosa and submucosa layers to protrude out through the breakdown in the layer. This creates a diverticulum that does not contain all the layers of the GI tract. It contains only the mucosa and submucosa, and for this reason it is called a false diverticulum, and results from a weakness or breakdown in the muscular layer. This commonly results from a chronic swallowing problem related to the cricopharyngeal muscle. This muscle needs to relax to allow food to pass through the esophagus. If it fails to relax properly, it makes it hard to swallow. Patients who have problems with their cricopharyngeal muscle will therefore generate high pressure in the pharynx to try and force food down their esophagus, and this chronic exposure of the mucosa to high pressure can lead to the formation of a diverticulum. The classic location for a Zenker's is a place called Killian's Triangle. This is in the hypopharynx, which is just proximal or just above the upper esophageal sphincter. And Killian's Triangle is located at the cleavage plane between the thyropharyngeus muscle and the cricopharyngeus muscles. If this is the pharynx and the esophagus, the cricopharyngeus muscle tends to wrap around it like this. The thyropharyngeus tends to come down at an angle like this. It forms a triangle in here between the two muscles, and that is called Killian's Triangle. The symptoms of a Zenker's diverticulum include dysphagia. There's a disruption in the normal functioning of the pharynx and the esophagus, and also classically halitosis. This occurs because food gets trapped in the diverticulum and erodes and decays, and this leads to bad breath. To make the diagnosis of a Zenker's diverticulum and also to work up a number of swallowing problems, you can perform a test called a video swallowing study. In a video swallowing study, you use a fluoroscope to take a video of a patient as they swallow solids or liquids. It allows you to visualize solids or liquids moving through the pharynx and into the esophagus. You can do this to work up a number of different swallowing problems. You will often see it done on elderly patients who have had strokes to see if they are still able to safely swallow solids. You can also do it to make the diagnosis of a Zenker's diverticulum. And if you look at this video swallowing study on the screen here, you can see this outpouching in the back of the throat. That is the presence of a Zenker's diverticulum, and the dark liquid material is being picked up by the fluoroscope as collecting in that outpouching, which is a Zenker's diverticulum. And that concludes our module on esophageal disorders.